Welcome to the Bariatric Surgery Program at UAB, a comprehensive center with the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. Let me introduce you to the bariatric surgery team. Dr. Richard Stahl is the Medical Director of Metabolic and Bariatric Surgery. He earned his MD at UAB, completed his general surgery residency at Caraway Methodist Medical Center in 1994, entered private practice in the Birmingham area for the next 16 years, and came to UAB in 2010. In addition to weight loss surgery, Dr. Stahl has a strong interest in surgical education, and he has performed between 1,500 and 2,000 bariatric surgical procedures over his career. Dr. Jaylene Grams earned her MD and PhD at UAB and completed her general surgery residency at the Mayo Clinic in Rochester, Minnesota in 2008. She did a fellowship in minimally invasive and bariatric surgery at Mount Sinai Medical Center in New York City and came to UAB in 2009. In addition to metabolic and weight loss surgery, Dr. Grams has an active basic scientific research program that investigates type 2 diabetes and obesity. She has performed over 200 bariatric procedures, and both she and Dr. Stahl have had excellent outcomes for their patients. Our clinical nursing staff includes Chrissy Lundeen. Chrissy coordinates care of patients in the clinic and is the primary contact person for patients with clinical questions or in need of instructions in the pre- and post-op periods. Test results will usually be communicated from Mrs. Lundeen. Janine Mays and Bree McGriff are both certified registered nurse practitioners. They assist Dr. Stahl and Grams seeing patients in the clinic and do the lion's share of short and long-term follow-up of bariatric surgery patients. Marcy Howard is the insurance coordinator and scheduler. She helps patients navigate the often lengthy process of obtaining pre-certification for bariatric surgery, including scheduling tests. Nakia McMullen, also a nurse, is the bariatric coordinator for UAB Hospital. She is the liaison between the bariatric surgery program at UAB and the MBS AQIP, otherwise known as MBS AQIP, our credentialing body. Nakia also coordinates the weight loss surgery support group meetings, Fresh Beginnings, facilitates postoperative education of the patients while in the hospital, and reports outcomes data on the patients undergoing bariatric surgery at UAB. So what is bariatric surgery and what are the indications for it? Bariatric surgery is the surgical treatment of morbid obesity. Degrees of obesity are determined by a patient's body mass index, or BMI. It is basically a weight to height ratio wherein a patient's weight in kilograms is divided by their height in meters squared. A normal healthy weight is a BMI between 18 and 24. Patients are considered overweight with a BMI between 25 and 29. The diagnosis of obesity begins at a BMI of 30. Class 1 obesity exists if the BMI is between 30 and 34. Class 2 obesity corresponds to a BMI 35 to 39, and Class 3 obesity, sometimes referred to as morbid obesity, begins at a BMI of 40. We follow the NIH guidelines that state bariatric surgery should be considered in appropriate risk patients with Class 3 obesity with or without comorbidities, or in patients with Class 2 obesity and certain comorbidities, that is, diseases caused by obesity such as type 2 diabetes, obstructive sleep apnea syndrome, hypertension, dyslipidemia, osteoarthritis, or degenerative disc disease. However, not all insurance policies follow these guidelines, and some policies may deny coverage even if a patient meets the NIH criteria for weight loss surgery. Some patients may have Class 2 or 3 obesity but still not be considered candidates for surgery. Contraindications for surgery include patients not healthy enough for major elective abdominal surgery, a past surgical history that would make bariatric surgery impossible or too risky, patients deemed not psychologically fit for bariatric surgery, non-compliant patients, and patients with substance abuse issues. Let's spend a few minutes describing each of the operations we do at UAB. The gastric bypass is one of the most common procedures done for weight loss. The stomach is first divided into a very small upper pouch, which is separated from the remainder of the stomach. The pouch is roughly 1 to 2 tablespoons in size, or approximately 1 ounce. The small intestine is then divided downstream from the stomach. The distal end is elevated over the stomach and the colon and attached to the small upper gastric pouch. The proximal end of the small bowel reattaches to the remainder of the small intestine about 3 to 5 feet downstream from where it was initially divided. After the operation, when a patient eats, the food, appearing blue in this animation, passes into the small stomach pouch, then into the intestine. Bile and pancreatic digestive enzymes, appearing green in this animation, flow through the other channel to mix with the food after it has passed 3 to 5 feet downstream. From that point onwards, digestion and the flow of ingested food is normal. Sleeve gastrectomy is a newer addition to bariatric surgery, but one that has become increasingly popular in recent years. Using a series of linear surgical staplers which divide and seal the stomach, approximately 80% of the stomach is removed, leaving a sleeve of stomach roughly the diameter of the esophagus, the tube which connects the mouth to the stomach. This decreases the capacity of the stomach to hold food and thereby restricts the volume of food that can be consumed at one meal. Unlike the gastric bypass, the full length of the stomach is retained, preserving the muscular valve at the bottom of the stomach, the pylorus, which slows food emptying from the stomach. But food, bile, and the digestive enzymes still follow the normal route through the GI tract. Laparoscopic adjustable gastric banding used to be a popular option. It is essentially an inflatable belt permanently implanted in the patient around the upper aspect of the stomach. First approved for use in the United States in 2001, there are currently 2 brands used, the Lap Band and the Realize Band. For completeness, there is a 4th common bariatric operation that we don't do at UAB, and it is the biliopancreatic diversion with duodenal switch. It is basically a combination of a sleeve gastrectomy with bypass of a large portion of the intestine. It has excellent weight loss results and improvement in comorbidities, but a higher rate of short-term operative complications and long-term nutritional deficiencies. Exactly how each of these operations work is still a bit of a mystery and an area of active research. But the primary goal of all 3 of the operations is severe restriction in the amount of food and calories a person eats. The adjustable gastric band simply squeezes the stomach, making it difficult for food to fit through, and thereby, hopefully, inspiring the patient to eat less. Bands seem to decrease a person's ability to eat, but not necessarily their desire. Patients who remain hungry eating healthy foods may gravitate to high-calorie foods such as sweets and snacks that fit through the band easily, thus satisfying their hunger, but prevent sufficient weight loss. We have largely abandoned use of the adjustable gastric band due to inferior results when compared with gastric bypass and sleeve gastrectomy. The sleeve gastrectomy and gastric bypass both seem to decrease appetite, presumably by altering secretion of several gastrointestinal hormones. Research suggests these operations augment secretion of some hormones that suppress appetite and dampen secretion of other hormones that stimulate appetite. In addition to having a favorable influence on diabetes, the operations seem to decrease the desire to eat. Some physicians feel the gastric bypass also causes malabsorption. That is, it decreases absorption of the food eaten. However, this is probably not true. The intestine is a very efficient organ, and even though a portion of the intestine is bypassed, Most of the digestible calories consumed are absorbed from the GI tract. There is, however, some decreased absorption of several vitamins and micronutrients. There are risks inherent in any operation. Each of the operations we are discussing are major surgery, and they share at least the following potential complications. These include, but are not limited to, bleeding, infection, injury to other structures, blood clots, anesthetic complications, conversion from laparoscopic to open surgery, development of gallbladder disease in 10 to 15% of patients, malnutrition, pneumonia, hernias, and death. There are risks somewhat unique to each operation as well. Specifically, the adjustable gastric band can slip, meaning it shifts from the position it was implanted to a different position of the stomach, possibly occluding the stomach. That would require surgical repair and/or removal. It can erode through the wall of the stomach to the interior of the stomach, necessitating surgical removal of the band. The port, band, or tubing could become infected, necessitating removal. The tubing connecting the port to the band can fracture and leak, causing the band to deflate. The leaking component would have to be surgically replaced. The port may rotate in its implanted pocket, making it difficult or impossible to access the device with a needle. That requires surgical revision. The band works by creating a partial obstruction at the upper portion of the stomach. That obstruction is known to cause functional problems with the esophagus in some individuals, and that may require deflating or even removing the band. It is important to know that bands have the highest complication and reoperation rate of any of the bariatric procedures we do. 15 to 30% of patients with a band will require a return to the operating room for problems related to the device. Although band complications tend to be less severe than sleeve or bypass complications, band complications are more common. Risks that are somewhat unique to sleeve gastrectomy patients include leaks from the staple line in 1 to 2% of patients. Leaks can be a severe and life-threatening complication, which may require reoperation, placement of stents, placement of drains, prolonged restrictions on eating, and other possibilities. Stricture describes a narrowing of the stomach channel that might make passage of food through the stomach difficult. It could necessitate endoscopic dilatation or even conversion of the sleeve gastrectomy to a gastric bypass. 15 to 20% of sleeve gastrectomy patients may develop gastroesophageal reflux disease, even if they didn't have it prior to surgery. Like sleeve gastrectomy, leaks can occur with gastric bypass at a rate of 1 to 2%. These can be very serious complications requiring reoperation, placement of drains, stents, or other interventions to treat the problem. Ulcers occur in 5 to 15% of individuals. Certain factors are known to increase the development of ulcers, such as smoking and use of non-steroidal anti-inflammatory drugs, including ibuprofen, Aleve, aspirin, BC, Standback, or Goodies powders. We advise against the use of these medications in patients undergoing gastric bypass surgery. Most ulcers can be treated by cessation of these activities and use of medications to reduce acid output from the stomach, but some ulcers may require surgical treatment. Stricture, or narrowing, of the anastomosis between the stomach and the intestine occurs in 3 to 5% of patients. The same activities that lead to ulcers can also cause stricture. Treatment is usually endoscopic dilatation, but may require surgical revision of the anastomosis, which is more difficult and risky than the original gastric bypass procedure. Intestinal obstruction due to adhesions or an internal hernia may occur often months or years after the original bypass. It requires surgery to fix. Vitamin and/or micronutrient deficiencies can occur with any of the operations, but they are more common with gastric bypass. Dumping syndrome we mention not because it is a risk per se, but to explain the phenomenon. Dumping syndrome describes the constellation of symptoms patients will experience if they eat or drink sweets. Prior to gastric bypass, food, including sweets, is held in the stomach and gradually released into the intestine after it has been diluted in the stomach. Food exits the stomach through a muscular valve called the pylorus. The pylorus is bypassed with surgery, so there is no mechanism to slow the exit of food and sweets from the stomach. Sweets are dumped into the intestine, drawing fluid rapidly into the intestine to dilute the sugar. However, this rapid fluid shift causes bloating, flushing, palpitations, nausea, and discomfort, usually within minutes of eating. Over the next 30 minutes to an hour, the patient may gradually feel better, only to feel terrible again an hour or two after the meal because of low blood sugar, ironically caused by the ingestion of too much sugar previously. This is called the early and late dumping syndrome, and patients that experience it will usually choose to avoid the types of food that caused it, sweets, which is exactly what we recommend. All operations carry risks of death and complications. Great strides have been made over the last decade in decreasing the mortality and morbidity risks of bariatric surgery. The risk of death from gastric bypass is approximately 5 out of 1,000. The risk of death with adjustable gastric banding is approximately 1 out of 1,000, and the risk of death with sleeve gastrectomy is about 4 out of 1,000. To put this in perspective, the mortality from more familiar operations is also listed. The risk of death from an appendectomy is about 1 out of 1,000, and about 3 out of 1,000 for a gallbladder operation. How do the operations compare in terms of weight loss and improvement or resolution of obesity-related health conditions? First, let's look at bypass versus band. In this study, a group of patients was randomly assigned to receive either gastric bypass or adjustable gastric banding. Bypass patients, represented by the blue line, lost 65 to 70% of their excess weight, while band patients lost 35 to 45% of their excess weight over 4 years of follow-up. Several other studies have shown similar results. On average, we find that band patients lose about half as much as bypass patients. We are generally not advocates of adjustable gastric banding. More studies are coming out comparing weight loss results of sleeve gastrectomy with gastric bypass. The sleeve gastrectomy is a newer procedure, however, so we have less long-term data on it. The graph shown here is from the San Diego Naval Hospital. They compared patients who had gastric bypass with those who had sleeve gastrectomy and followed them for 5 years. Bypass average weight loss results are in blue, and sleeve results are in red. The graph shows equivalent weight loss over the study period in both groups. However, one caveat to notice. At the 5-year mark, there were only 12 people in the bypass group versus 14 people in the sleeve group. That is not a large group to allow a definitive conclusion to be drawn. Several other published studies have followed patients for 3 to 5 years, and they have variously shown weight loss results of sleeve patients to be either equivalent to or slightly less than gastric bypass patients. There is no convincing evidence that sleeve gastrectomy achieves better weight loss results than gastric bypass, and there are very few studies that have followed sleeve gastrectomy patients for longer than 5 years. We don't know the long-term success of sleeve gastrectomy. Besides losing weight, bariatric surgery hopes to improve patient comorbidities, that is, other obesity-related conditions such as diabetes, sleep apnea, hyperlipidemia, and high blood pressure. The graph shown is from the University of Michigan. They compared resolution rates of those conditions for patients in their state undergoing bariatric surgery with one of the three operations we are discussing today. Each of the triple columns depict a medical condition associated with obesity. NIDDM, or non-insulin-dependent diabetes mellitus, sleep apnea syndrome, IDDM, or insulin-dependent diabetes mellitus, hyperlipidemia, and hypertension. The leftmost of the three columns depicts gastric bypass, the middle column is sleeve gastrectomy, and the right column is adjustable gastric banding. An asterisk at the top of the column indicates the difference between it and the center column is statistically significant, that is, not presumably due to chance. Looking first at the two diabetes columns, we notice that gastric bypass was statistically significantly better at resolving diabetes than sleeve gastrectomy, and sleeve gastrectomy was statistically significantly better than adjustable gastric banding. The same is true for hyperlipidemia. Looking next at sleep apnea syndrome and hypertension, we find that both gastric bypass and sleeve gastrectomy were statistically significantly better than banding at causing resolution. But the difference between bypass and sleeve was not significant. In other words, they were roughly equivalent. Interpreting this, we think more research needs to be done, but there may be an advantage that gastric bypass has over sleeve gastrectomy in the treatment of diabetes and hyperlipidemia. So, now that you hopefully have a better understanding of bariatric surgery, the goals, the risks, and how the operations differ, let's talk about the process going forward. Most of you that are listening to this presentation have already received and read the weight loss surgery information packet from our office, and you have filled out the demographic forms and taken a test on the material you have read. If not, that is required before a consultation visit can be scheduled. Likewise, for most of you, today is your initial consultation visit. It is at this visit that we will try to determine if you are potentially a candidate for surgery. Insurance coverage for bariatric surgery varies greatly from company to company, and even within companies depending on the policy. You are encouraged to contact your provider and specifically determine if weight loss surgery is a covered benefit. If so, what is required of you to qualify? If not, is paying for it out of pocket a viable option? The typical private pay cost is in excess of $20,000. Plan to attend one of our support group meetings. It is a requirement to attend at least one meeting prior to surgery. Prior to obtaining insurance pre-certification, all patients will have a lab panel drawn. Patients desiring sleeve gastrectomy will have a upper GI done, wherein you will be asked to drink some contrast while x-rays are done to look at your esophagus, stomach, and swallowing mechanism. Prospective gastric bypass patients will have an EGD scheduled to evaluate the stomach, especially the portion that will be bypassed, to assure there is no worrisome pathology in that portion that may need to be addressed. Once the gastric bypass is done, there is no way to access that portion of the stomach easily in the future. Depending on your overall health, your past medical history, or your insurance company, you may be required to be cleared for surgery from other physician specialists. Obesity is the number 2 leading cause of premature death in this country. Smoking is the number 1. Insurance companies and we require you be completely tobacco and nicotine free for at least 2 months prior to surgery. This includes smokeless tobacco, electronic cigarettes, nicotine patches, gum, and other forms. If you are a current smoker,
tobacco user, or nicotine user, we require 2 negative consecutive monthly nicotine tests to prove complete cessation. Some patients may be required to have a psychological or psychiatric evaluation prior to surgery. All patients must go through nutritional and dietary counseling with our dietitians. Many insurance companies require proof that the patient has been continuously morbidly obese for 3 or 5 years prior to the request for bariatric surgery. This usually necessitates records from the primary care physician wherein the patient's weight has been documented. If those records are not available, or weights were not recorded, some insurance companies will consider dated photographs of the patient going back the required amount of time, which visibly document morbid obesity. Insurance companies will not consider letters from a physician stating the patient has been obese for that period of time. Many insurance companies require patients to participate in a physician-directed or supervised weight loss program prior to consideration of surgery. If so, that diet must usually be 3 to 6 months long, include behavior modification, dietary counseling, and documentation of physician visits, often monthly. Also, that diet usually has to be done within the previous 12 months. Physician-directed diets longer than 12 months ago may not qualify. We strongly recommend researching the particulars of an insurance-mandated preoperative diet, especially with your particular policy, as it varies considerably between policies. If a patient diets but doesn't do it in the manner prescribed by their policy, their insurance company is unlikely to approve surgery. Risks of complication and death associated with surgery increase with the weight of the patient and the associated comorbidities patients have going into surgery. For this reason, we may require patients to lose weight prior to surgery, often 10% or more. The UAB Weight Loss Medicine Clinic is an excellent program to help achieve that.
Once all the preoperative requirements of the program and the insurance company have been met, our office will submit a request for insurance pre-certification for weight loss surgery. Assuming a favorable response, a mutually agreed upon date of surgery will be set. Patients will return to our clinic so that we may update the medical history and physical exam, complete preoperative admission tests and paperwork, undergo pre-anesthesia screening, and answer any additional questions. All patients will attend 2 bariatric surgery nutrition education classes prior to their operation. There is an additional $100 charge for this program, and it is mandatory. The first class will cover the preoperative diet. All patients are required to go on a 2-week protein-sparing, very low-calorie, low-carbohydrate diet immediately preceding surgery. Patients will have to purchase some meal replacement products for these 2 weeks, and those choices will be discussed during class. If properly done, the diet will result in significant weight loss prior to surgery, lowering of blood sugar in diabetic patients, and shrinkage of the liver, which is often enlarged in obese patients and restricts surgical access to the stomach. The same class will also review diet progression over the first 2 to 4 weeks after surgery and recommended supplements. The second class covers the later diet progression beyond the first 2 to 4 weeks, as well as lifelong dietary restrictions and recommendations. We also recommend patients refresh their memory of the lifetime diet by repeating bariatric nutrition class number 2 a few weeks after surgery. That's included in the initial charge for the classes. It's very important not to eat or drink anything after midnight the night before the operation. Patients are asked to arrive several hours before the case, which usually lasts 2 to 3 hours. After the operation, patients go to the recovery room for typically 1 to 2 hours, then are transferred to a hospital room. Gastric bypass and sleeve gastrectomy patients will have an upper GI x-ray the morning after surgery to check for leaks and the integrity of the newly fashioned stomach. Patients then start a clear liquid diet for a day. If that is tolerated, diet is progressed to food of a pureed consistency for the next 3 weeks. Then soft food, described as fork tender meats and foods you could eat if you didn't have teeth, for 2 to 3 weeks. Then a regular diet starting about 6 weeks after surgery. Most patients go home 1 or 2 days after their operation.
After discharge, patients are usually seen again in 2 to 4 weeks, then at 3 to 6 month intervals the first 1 to 2 years, then annually. Labs are checked every 6 to 12 months the first 2 years, then annually thereafter. Successful weight loss surgery requires drastic lifelong changes in patient behavior and eating. The typical diet is roughly 400 calories per day immediately after surgery, but gradually triples over the course of a year. When patients are consuming so few calories, it is easy to become protein deficient. Thus, protein becomes the most important component of a meal, especially during the most active period of weight loss. It is sometimes necessary to take a protein supplement. Sweets and calorie-laden beverages should be avoided. Patients should take very small portions, turn off the TV and any other distractions, sit down to eat their meals, take very small bites, and chew their food very well. Exercise is extremely important to maintain weight loss. At a minimum, patients should do at least 4 hours per week of aerobic exercise. All patients require vitamin supplementation. There are numerous ways to get these vitamins and numerous brands. They don't require a prescription. We recommend at least 1 multivitamin with iron daily, a sublingual vitamin B12 supplement daily, and a calcium plus vitamin D supplement, such as Citracal, twice daily. Many obese women actually suffer with infertility. Losing weight may increase fertility. However, we strongly advise against pregnancy during the period of time patients are losing most of their weight, generally for the first 1 to 1.5 years. During that time, it is important to use birth control. At this time, we will entertain any questions you might have. Thank you, and good luck on your journey.